Well, good morning, everyone. I'm so happy to be here this morning. I'm covering for Dr. Suzanne Mazur. I'm Susan Marshall, and welcome to Grand Rounds. I'm so excited because I get to welcome one of my colleagues, Dr. Laura Ellington, to do Grand Rounds this morning. So welcome to those in the auditorium. Welcome to all of you online. If you are online, we would love for you to mute. And at the end of the presentation, we'll take questions. We'll both have questions from people in the audience, and we'll be tracking questions online as well. So I would like to start by introducing Dr. Katie Nielsen and Dr. Amelie von St. Andre, who will introduce our speaker today, who is Dr. Laura Ellington from our Division of Pulmonary and Sleep Medicine. So thank you so much.
So good morning, everybody. We are so excited that you are here today for our first Global Health Collaborative supported Grand Rounds. We are thrilled to share some of the exciting work that is going on right here at the University of Washington. Just as a background, the Global Health Collaborative is a UW Pediatrics committee that supports faculty and fellows pursuing global health academic work. It is supported by Dr. Leslie Walker-Harding. Thank you very much for your support. We focus on promoting collaborations throughout the University of Washington, specifically working with the Department of Global Health and Global Watch. This is our leadership committee in case you have questions or would like to be connected in the global health arena locally. Our current activities for GHC include a global health track for pediatric subspecialty fellows that was launched this year. We also do global health seminars for global health track fellows, but also any faculty who is interested. And our next session is on January 31st, if you would like to join. We also organize works in progress, both for faculty and fellows in global health. And again, our next session is on January 31st, and anybody is welcome. And we do networking events for faculty and fellows in global health, and we are very excited to have our first networking event with Global Watch today at the Hans Rosling Center from 2 to 4. So again, if anybody is interested and would like to connect with our colleagues in global health at the Department of Global Health and Global Watch, please join us. And then lastly, we do now support Global Health Grand Rounds, and Katie is going to talk more about that.
Good morning, everyone. Nice to see all of you. So we're just thrilled to introduce Dr. Laura Ellington, who is an assistant professor in the Division of Pulmonary and Sleep Medicine here. Dr. Ellington really has an extensive track record of success in pediatric global health research. Starting in medical school at Johns Hopkins, she was awarded a Doris Duke Clinical Research Fellowship to study lung ultrasound and electronic auscultation in Lima, Peru. Then she came here for residency, and I had the pleasure of working with Laura on a project implementing high-flow nasal cannula and a PICU in Lima, Peru. I could not convince her to be a pediatric intensivist, despite many efforts. She decided that pulmonary was her future. And so during her pulmonary fellowship at UW, she completed a Master of Science in Epidemiology and started building collaborations in East Africa, which she continues now since she's joined faculty. As junior faculty, she completed the UW K-12 Implementation Science Training Program. And now as a physician scientist, her work is focusing on optimizing and evaluating a mobile health decision support tool to improve diagnosis and management of acute lower respiratory infections, the leading cause of global pediatric death outside the neonatal period. So with pleasure, we invite Dr. Laura Ellington to share more about her exciting work.
Thank you all again for coming, and thanks to everybody online. I'm excited to talk about my work today, and this talk is entitled "The Kids Are All Right: Advancing Pediatric Respiratory Care in Uganda Through Digital Innovation." I have nothing to disclose. Objectives today are to assess the global burden of pediatric respiratory illnesses and disparity in care globally, assess innovative approaches to improve the implementation of evidence-based pediatric respiratory diagnosis and treatment in low and middle income countries, or LMICs, and to implement training and build partnerships to support a meaningful career in global health. My pathway into global health started really in college when I volunteered at a community health center in Costa Rica. The experience really changed me, and when I went to med school, I wanted to learn more about how to make global health a viable career option. In med school, I had the opportunity to spend a summer in India doing what I now consider implementation research in a community eye clinic. And I don't know if you can tell what I'm holding in my hand, but that is a camera that we used to use to take pictures before iPhones. So this dates me a little bit. I then shifted my career focus from ophthalmology to pediatrics and designed a project under the mentorship of Will Checkley, like Dr. Nielsen was talking about, to evaluate lung ultrasound and electronic auscultation for pediatric pneumonia diagnosis in Peru. Global health was a big reason for applying here for residency, and global health is where I became interested in pediatric pulmonology. Dr. Katie Nielsen, seen here, was a huge inspiration early. As she mentioned, she mentored me on a high-flow implementation project in Peru during residency. My career focus has been to improve pediatric respiratory outcomes in low and middle-income countries, but why respiratory illnesses? So acute lower respiratory illnesses are the leading cause of death in children under 5 years, responsible for almost 700,000 deaths in this age group worldwide. And there is huge disparity in pediatric ALRI mortality by region. On the left panel, you can see that over time, ALRI mortality has thankfully declined. However, there's a massive gap in deaths in sub-Saharan Africa versus the rest of the globe. And on the right panel, you can see in the map the similar distribution where most of the mortality is in sub-Saharan Africa. And to put it into perspective, in the USA, about 2 deaths per 100,000 children under 5 from ALRI, whereas in Uganda, where I primarily work, that's over 100 deaths per 100,000. So how are ALRI diagnosed and managed in LMICs? So primarily through this booklet by the World Health Organization that was developed in the 90s, put out in the early 2000s, and most recently updated in 2014. This is the Integrated Management of Childhood Illness that provides health workers with assessment guidelines for common childhood complaints. And specifically, the guideline for cough or difficulty breathing looks like this. So if there are danger signs present, which can be vomiting everything, convulsions, or stridor in a calm child, there's a diagnosis of very severe disease, and the recommendation is to refer urgently to higher level health facilities, specifically hospitals. Now you look at the diagnosis of pneumonia, and the only real criteria are chest indrawing or retractions or fast breathing. With that diagnosis of pneumonia, the recommendation is to give oral antibiotics and close outpatient follow-up. Now, I'm sure many of you are kind of thinking, well, I can think of many other things that lead to fast breathing or chest indrawing in this population. So this is quite a sensitive but not a very specific guideline. Fortunately, in 2014, the guidelines were updated to consider wheezing illness and to give a bronchodilator and consider also asthma management in this population. So let's think a little bit more about ALRI definitions. As I mentioned, the guidelines that are used in LMICs are really quite sensitive but not specific. And when we think of ALRIs, many times it's used interchangeably with pneumonia, and we're thinking about bacterial pneumonia in this setting. But I think about ALRIs in 3 big buckets. So we have bacterial pneumonia, which is, of course, an important contributor to morbidity and mortality in this population. Viral illnesses, of course, are really, really common, and these are not drawn to scale by any means. But I also think about asthma syndrome. And when I say asthma syndrome, I think about bronchodilator responsive wheezing illness. And the latter group constitutes a major overlooked category of ALRI. In fact, multiple studies and LMICs have demonstrated that about half of children with WHO-defined pneumonia actually have wheezing, and in many cases, bronchodilator-responsive disease. And in particular, in Uganda, Dr. Rebecca Nantanda, my primary collaborator, did this really formative work where she reviewed all children, so over 600 children, who were admitted to the National Referral Hospital in Uganda with severe pneumonia, and recharacterized 41% of them with asthma syndrome. And in looking through those who were diagnosed with asthma syndrome, about half of them ended up having bronchodilator reversible disease. So this tells me two things. One is that there is a need to consider and think about bronchodilator reversible disease in this population and offer additional treatment recommendations and approaches. And also that antibiotic overuse is a really massive problem in this population as well. That 94% of these children who had bronchodilator reversible disease and no pneumonia ended up receiving antibiotics during their stay. And asthma in particular is the most common chronic disease of childhood, as we all know, and that symptoms often start before age 5. At least 400,000 children die primarily from asthma in LMICs and primarily in sub-Saharan Africa, and the prevalence of asthma is increasing, and there is a strong link to asthma and COPD later in life. So we've reviewed what ALRI is and what the guidelines recommend, but how is ALRI managed in different countries? The Fresh Air Project helped to answer these questions by understanding current practices in these 4 countries. The Fresh Air team included Dr. Nantanda, who I've mentioned previously, and Dr. Jim Stout, who many of you probably know. But before I go into the findings from the Fresh Air Project, just a little bit more about Uganda. So Uganda is classified as a low-income country by the World Bank. There are 42 million inhabitants, and mortality rate in children under 5 years is 64 per 1,000. 13% of that is attributed to ALRI. And there are massive shortages in the healthcare workforce. So 0.04 physicians and 0.09 nurses per 1,000 persons. And to put that into perspective, the US has 2.6 physicians and 12 nurses per 1,000. And a little bit more about the Uganda National Health System. So there are 6 tiers of levels of health facilities. And at the bottom level, there are the most, but the least resources. And as you go up the pyramid, there are fewer and more resources. So for example, the village health team consists of community health workers that are in many villages. But as you go up the chain, the health centers, levels 2 through 4, are where the vast majority of primary care is located. And then there are district hospitals, regional referral hospitals, and 1 national referral hospital. And I'm going to narrow in on health centers, which is where the Fresh Air Project focused and where our work is focused as well. And we chose primarily health center 4s because that's where the point of entry for most children in the health system occurs. This is where primary care, basic inpatient services, and maternity care exists. And they are performed by clinical officers, which are, you can think of similar to advanced practice providers here in the US, and nurses provide the majority of the care. And the resources kind of vary from health center to health center, but in general, these are very high volume centers that for children under the age of 5 years with respiratory illnesses, there are about 100 to 250 per month at each of these facilities. Due to the COVID pandemic, there's actually been improved access to pulse oximeters and oxygen therapy, but stethoscopes are really rarely available. Antibiotics and steroids are, but inhaled bronchodilators are not. So what did the Fresh Air study show? Really, in Ugandan health centers, respiratory evaluations are quick and incomplete. The median length of the visit is about 4 minutes, and when we performed, or when exams were performed, only about 21% of health workers exposed the chest to evaluate for breathing. 11% the respiratory rate was counted, and only about a quarter of visits the stethoscope was used. And as a reminder, these are all children under the age of 5 who presented with a chief complaint of cough or difficulty breathing. That asthma or wheezing was never diagnosed, despite caregivers reporting recurrent respiratory symptoms, and antibiotics, even for the diagnosis of viral illness, were commonly used. So this leaves a lot of room for improvement and an important high-yield target for a low-cost, sustainable intervention. And this is where I come in. So based on these results, Jim Stout and Margaret Rosenfeld approached me with a fellowship project idea to develop a mobile health tool for health workers in these settings, which led to me meeting Rebecca Nantunda at the IPCRG conference in 2018, leading to sustained collaborations with incredible people at the McCary Lung Institute and the University of Washington Departments of Global Health and Computer Sciences. So I just wanted to highlight a few people here. So on the left, this was from our first visit in 2020, and you may be able to see Margaret. Stephanie Farquhar is a professor in the School of Public Health. Irene Najingo is our research coordinator, and we had 2 amazing research assistants. Over on the right, this was from my most recent visit in 2023. So you can see our growing and incredible team. And then in the middle, Dr. Joyce Nabinde from the McCary Information Sciences Department visited this summer. So this was at Mio Posto up in Ravenna, having lunch with Richard Anderson, a computer science professor, Jim Stout, Rebecca Spur, one of the pulmonary fellows, Lisa O'Rai, which is a PhD candidate, and myself. And so why mobile health? We chose to pursue mobile health because a health worker in Uganda is more likely to have access to a smartphone than a stethoscope. And access to mobile technologies is growing. There has also been promising results that mobile health tools have helped to improve IMCI guideline adherence compared to paper tools, that in general they're quite acceptable and usable, but few have achieved large-scale implementation and none have really focused on asthma management. So we developed the Acute Lower Respiratory Treatment and Evaluation Tool, or ALRITE, a point-of-care decision support tool for health workers, specifically in Uganda at this point. It leverages the backbone of existing WHO IMCI guidelines and adds wheezing illness decision support with adapted respiratory score and bronchodilator assessment. The basic flow of the app starts with the patient demographics, then triage, history, and we embedded a respiratory rate counter that's semi-automated, along with a focused respiratory exam that requires the health worker to input all of their findings. A bronchodilator trial, if indicated, and then age and weight specific diagnosis and treatment recommendations. So here are some screenshots of example history questions, and then the second panel is the respiratory rate counter, where you tap the start button every time the child inhales. It keeps track of how many breaths that is, and then when it has determined the respiratory rate, provides the final respiratory rate along with whether it meets criteria for fast breathing or normal breathing by the World Health Organization. We have an educational toolkit where we provide information on delivering bronchodilators, how to make a spacer from a plastic bottle, et cetera, as well as diagnosis and treatment recommendations, as you can see on the right, that are age and weight specific, as I mentioned previously. And so as an implementation scientist, I think a lot about how interventions work and how they should work. And I think that this is a really important exercise, especially for complex interventions like mobile health technologies. So thinking about what components are critical and how they might impact care. And the proximal outcomes can be measured and determine whether they lead to the eventual distal outcomes of health changes and improvements. So it helps to think about causal pathways and as well as areas for improvement, adaptation. And when adding features, you can also think for additional pathways and how those features may or may not improve your hopeful outcome. So when we think about the decision tree for ALRITE, we think that the decision tree with current guidelines, the dashboard, and patient education are all critical components. And that they will lead to the eventual improved ALRI outcomes through health worker self-efficacy and knowledge building, through building capacity by improving triage and referrals, and improving the caregiver's knowledge of the child's disease. And so where are we and where are we going? This kind of gives an overview of all of the things that we have kind of set off to do since the inception. And this has been a very iterative process, and we've taken a lot of feedback and improvements and changes on the small and the large scale to try to make this tool a really useful intervention for our end users. So I've talked a bit about partnerships and how ALRITE was developed, and now we'll talk a bit more about our testing. So we went to Uganda for the first time in 2020, and I wanted to give a shout out to the physician relations team who supplied me with a lot of children's swag, which the health workers were very happy to get, and so they were showing off their swag for us during one of the meetings. And we have a really incredible team and was able to travel again in 2023. And you can see a group of very happy health workers after one of our training sessions. And I've had a little bit of time to do some mountain biking while I was there as well. So what were our findings? So when we did our preclinical field testing, we enrolled 25 health workers and 3 medical directors from 2 health center 4s. We were pretty surprised to know that essentially all of them had a mobile phone, and over 60% of those were smartphones. That they really enjoyed working with the phone. They found a lot of perceived benefit for its use. And through focus group discussions, they told us they were all very optimistic about integrating ALRITE into their health system and were not particularly worried about the time requirements. They said that they would get used to it and it would become kind of a routine for them. But they also said and highlighted the importance of engaging caregivers, which we took and used as they were participants in our kind of follow-up study. And they really were worried about caregiver acceptability of this new tool, thinking that health workers would be on their phones and on WhatsApp and not paying attention to the children. So that was a point of further evaluation that we required, along with healthcare administrators for buy-in and consideration for scale-up. They also gave us plenty of specific feedback on the app itself, and we use that to improve the design for clinical testing in the future. So we're very excited about this. We're ready to go. And then COVID happened. I literally flew back the week before the first reports in Seattle of COVID. But there were a few silver linings from the COVID pandemic with our work. One is that we were able to think hard about how to continue our research in the US locally to advance our global project. And 2, we got much better and really good at working together apart. We implemented regular virtual research meetings 1 to 2 times a month that we still have to this day with our Ugandan and our Seattle partners. And we also kind of shifted thinking, and instead of feeling the need for me to travel to Uganda all the time to do the work, to think more about how to support and shift funds to our international partners to do their work. So in the vein of doing work locally, we did a respiratory rate counter validation project that was led by Rebecca Spur, then resident, now fellow, where we wanted to know how our respiratory rate counter functioned, and was it the right tool to integrate into ALRITE, or did we need to think about another commercially available option for respiratory rate counting? And I think many of you will probably appreciate how difficult it is to count the respiratory rate, that there are no great tools, there are no automated tools that work, that are low cost and work well. And the WHO suggests this counter that you can see in the top right with beads to help you keep track. But it's additional stuff that you have to carry, and it also doesn't work all that great. So we developed a respiratory rate counter within ALRITE, as well as using this commercially available and previously studied option called ALRITE. We enrolled 39 healthcare providers here at Seattle Children's and asked them to use these tools on a standardized set of videos of children less than 24 months with respiratory distress. ALRITE respiratory rate counter was accurate and user-friendly, so 84% of readings were correctly classified, and almost all participants thought that it was easy to use and felt confident using it. And you can see in comparing the reference reference readings along with the participant readings, that ALRITE had a Spearman correlation coefficient of 0.83, which is pretty good. And that was better than our rate that had a bit more scatter. And so we decided we're happy with our respiratory rate counter, and we felt ready for clinical field testing. So our initial field testing took place at 2 health center 4s, so the same health center 4s that we went to previously. We enrolled 7 clinical officers, so all of the eligible clinical officers that worked at these 2 health facilities. Due to ethical concerns from the Ugandan Ethics Committee, they felt like this was an early enough study that it wasn't ready to put in the hands of health workers who had less training, like nurses and midwives, so they limited our enrollment to clinical officers. We considered our intervention package to be not only ALRITE-enabled tablets, but also a standardized clinical and technical training at the beginning, as well as kind of some refresher trainings, and the supplies needed to diagnose and treat respiratory illnesses in this setting. We encouraged participants to use ALRITE in clinical care for 3 months, but use was not required. We performed weekly virtual check-ins and monthly site visits to really troubleshoot and get feedback from people on how things were going, and offer the opportunity to do any updates to the app if there were any technical errors or issues that needed immediate fixing. And we had a local pediatrician from the Ginger Referral Hospital who was a consultant and provided ongoing training at the health centers. And all of this also happened while I was on maternity leave, so it was an incredible amount of work done as I was home with my baby. And so, to be honest, the results were not exactly what we were hoping for. ALRITE was used in only 14% of encounters, and while there were 5 active users at 1 month, only 2, 1 at each site by 6 weeks into our study. We were happy that concordance between the ALRITE diagnosis and primary health worker, and the health worker primary diagnosis was high at 71%. And when we look through all of the times for discordance, the discordance really came from health workers not fully understanding how the danger signs were worded, and so they kind of overcalled severe disease, and so inputted that into the system, and then ALRITE kind of overcalled severe disease for that reason. And because there was such low use, we also didn't see any change in the diagnosis of asthma syndrome or pneumonia over time. And importantly, time to complete ALRITE was 4 minutes, which you'll remember was about the time of consultation from the fresh air work. That a stethoscope was never used, and abnormal breath sounds were also rarely identified, and a bronchodilator trial was rarely given. Thankfully, we included focus groups as part of the study to really better understand these quantitative results. We learned from health workers many of the barriers to ALRITE use, and these aren't really earth-shattering, but they spoke of time and limited staffing and the challenges with the new technology and really having the time and space to practice with it. so that they felt comfortable using it in clinical care, especially in front of caregivers. They spoke to the limited scope of ALRITE, that it just focused on respiratory illnesses, where they were seeing kids with all sorts of illnesses and those with respiratory complaints, along with concerns for malaria and kind of co-infections. Duplicate data entry was an issue. All of these health centers have paper health records, and so they had to input things into an app, and then they also had to write something in a health record. And then some of them reported whether or not they had a pulse oximeter on site, it was not always available to use during their outpatient clinic visits and was often kind of whisked away to the maternity or inpatient ward for those purposes. But we also heard themes from our thematic analysis that I have to give a lot of credit to Noella Liu, a medical student that we've been working with, where health workers and caregivers also discussed how they felt ALRITE improved asthma care. So one health worker said, we used to reserve the diagnosis of asthma for adults, but now we are assessing children for asthma too. Another health worker said, I managed to save a child with severe distress syndrome who had difficulty in breathing and had a wheeze. This child improved because we had a nebulizer, we had a spacer, we had the drugs, and you see it made my work easy. And then the mother was like, we are going to give the child your name, and brought me a hen her appreciation. And a caregiver said, the health worker brought that spacer and the salbutamol and put it on the child, and in minutes the child was okay. She calmed down and the difficulty in breathing stopped. I was amazed. And so really glad that we got this qualitative data because it was not accurately reflected in the quantitative work that we had done. And health workers and caregivers also talked about how it improved knowledge of the health workers and patient satisfaction. So a health worker said, those cases used to be for referral, but now they are being managed here. People have the skills because of this program. And a caregiver said, please continue with ALRITE because it's fast and informs the right diagnosis, unlike the traditional treatment where health workers waste time telling you to go to X-ray and blood test, which sometimes cause delays, ending in death at times. So the focus groups were heartening, and we realized the impact of building capacity in these health centers was huge, but we had more work to do. Thankfully, I was awarded a K-23 to continue this work, and the first aim of my K was to understand just that. What strategies can we employ to improve uptake and sustainability of ALRITE? And we did this by prioritizing barriers and solutions and thinking more systematically about improving ALRITE optimization. So this was a mixed method study where we expanded from 2 to 8 health centers. We involved 2 health center 3, so lower level health centers, and we also expanded to a district and regional referral hospital. And that expansion to higher level health facilities was led by these dissemination and engagement meetings we had where members of these facilities wanted ALRITE, and they wanted us to include their sites as study sites, especially because they were where these health centers were referring to and wanted to know kind of what was going on and to learn from the program. So we enrolled 66 health worker participants. And there was a pretty good spread. There were fewer medical officers or physicians, and about a quarter of clinical officers, 36% nurses, and most of the other providers were midwives, all engaging in primary care for children who are coming in with respiratory illnesses. And we did this through 2 sets of focus groups. The first focus group, we had health workers brainstorm and rank their barriers by importance and by how common they felt the barriers were. And you can see on the left, you have health workers that are coming up with Post-it notes. It was a very engaging session, and they're kind of ranking what they feel is the most important. We then, as a research team, analyzed the barriers and prioritized them, and then went back to the same health workers and asked them to think about solutions. So to brainstorm solutions in a similar way and to rank those solutions by how important they were and how feasible they felt they would be. We developed this go zone plot of ALRITE barriers by importance on the x-axis and commonness on the y-axis. You can see the scatter really kind of showed what people felt were the most important. So lack of resources were certainly really important and something to address. ALRITE scope, as I mentioned, that we were really focusing on a small group of diseases and things that the health workers saw. Training, ALRITE speed, or the time it took, and health system integration, we kind of combined into one barrier, and then caregiver acceptability, as I brought up before. And we were really amazed by how creative the health workers were in coming up with promising solutions. And I've just showed and highlighted a few of these solutions that we'll be integrating into our next phases. So one, for limited resources, they talked about improvising spacers using plastic water bottles, which is an evidence-based approach to using spacers using spacers when the commercially available option is not available. And for health workers themselves, lobbying to different organizations for the resources that they need to care for children. As far as the scope and the algorithm itself, they talked about providing additional support references like charts in exam rooms. They wanted visuals to help to complement the digital tools that they were using. And for training, they talked about making a sustainable and iterative training program, as well as having repeat trainings. And so incorporating into their existing CME infrastructure and identifying local champions that could continue to take this work forward. For integration into workflow, they talked a lot about triage, both in strengthening their own triage systems for children and integrating ALRITE into those triage systems. And then for caregiver acceptability, there are existing group health education that occurs when there's a new intervention or a new program at health clinics. And so they wanted to adapt ALRITE to those group health education visits and make sure that ALRITE is introduced at every consultation. So we have our work cut out for us. Thankfully, we have a plan to address these barriers, and we're starting with the ALRITE intervention itself. We're beefing up our training program, undergoing a complete app redesign, and continuing to meet with stakeholders and brainstorm about the health integration piece. So if you have any ideas about how to integrate this digital intervention into paper records, please let me know. I would love to hear them. And so for the training program, we are and will be formalizing an ALRI curriculum that's specific to these health centers that will have visiting lecturers, probably mostly led by Rebecca and Nantanda and our local pediatrician consultants, while building local experts to talk about various aspects of ALRI diagnosis and management. And taking input from the health workers, we'll be integrating this into the existing CME infrastructure. I'm really excited to announce the partnership that we have just started with Global Strategies. Global Strategies is a nonprofit that has created a tool and platform called NoviGuide. NoviGuide is an existing platform that has been used to package complex guidelines, particularly in neonatal care, into usable digital tools specifically in low and middle income countries. So applications generated have been used on over 32,000 assessments to date in Uganda and other African countries, as well as in the United States. And this is really made possible by the funding from the Center for Respiratory Biology and Therapeutics, CSRI, which we were awarded to start this partnership. And this really also offers the potential for us to expand and leverage their existing partners to scale and to make this a really sustainable product. I'm also really excited about automated diagnostics by these and other companies that are coming down the pike. that may be integrated into ALRITE when they are ready. They're just not quite ready yet. So there are many groups that are working on automated analysis of lung sounds and cough to help to diagnose and differentiate wheezing illness from pneumonia, as well as thinking about automated ways to diagnose respiratory or to evaluate respiratory rate and work of breathing, along with low-cost pulse oximetry solutions and lung ultrasound that may even use the native app. So all of these really exciting technologies are underway, and we're excited to hopefully be able to integrate them into the future and help to provide more objective assessments for respiratory disease in this setting. So now where are we going? We have come a long way. We've tried to integrate a lot of user input. We've tried to understand the context in which we work. We have tried to really develop a tool that can be sustainable, that can be used, and that can be feasible in these settings. And along with the ALRITE redesign, we'll be doing rapid phase testing of this new design to ensure that it can be used in the setting and that it will be used and adopted. And then we'll test the tool, its use and implementation, along with the effectiveness and the potential for health outcomes. And we'll do this through field testing, a 1.5-year time series analysis that we have planned coming up as part of the K23, as well as scaling up and evaluating more the effectiveness, scalability, and sustainability. So as I end this talk, I wanted to give a little bit of advice, unsolicited, for those who may be interested in global health that I've learned from the many years that I've been doing this. First is to start small, that it doesn't have to be big, that little interventions can go a really long way in many low resource settings. And it can also, we can think about all of the low resource settings here domestically that can benefit from innovations like this. Meet with people, meet with lots of people, attend seminars, learn. The UW is a fabulous place to be, to get excited and inspired and to see what all amazing work that people are doing across the globe. Get training. I feel like I am truly a lifelong learner, and it's been fun to expand and think about things that I know nothing about, like mobile health technologies, and thinking about new innovative ways to test them and to adapt them to settings. I think really importantly, establish international bidirectional partnerships, and this has been one of the best parts of my job, honestly, is to have amazing mentors and collaborators from really all around the world. Understand the context in which you're working, understand the needs of those who live and work there, and that a lot of times means visiting and spending time in these places and getting to know people there. And above all, show patience, humility, respect, and I cannot discount enough persistence, even when all things are telling you to quit. So in conclusion, ALRI mortality is exceedingly low in the US, but it is the leading cause of death in young children worldwide. That asthma is an important contributor to respiratory morbidity in LMICs. That digital innovation is a promising strategy to improve evidence-based care in these settings. Partnerships, feedback, and iterative improvement is so valuable for the eventual adoption, sustainability, and impact of complex interventions. And I firmly believe that global health is a viable, rewarding career for those with a passion for collaboration, problem solving, and potential for high impact. So I wanted to put a few resources for those who are interested in getting involved or learning more. I think Katie and Amelie also already discussed the Global Health Collaborative, and check out their website to learn more. There is a wealth of resources on the Department of Global Health. There are a lot of different trainings that you can do, either kind of short courses or online trainings through the University of Washington and elsewhere. If you want to learn more about implementation science, there's a great website that UW hosts. Mobile health, there are a lot of new trainings, and in our residency and fellowship as well. I'd just like to say thank you to everybody for attending this talk, to the Global Health Collaborative for the opportunity to speak, and the amazing mentors, collaborators, and people that I've been able to work with through this journey. Thanks.
Hi, everyone. I'm going to come into the audience and see if folks have questions, and then we'll also take questions from people online. So, Dr. Ellington, that was absolutely amazing, and I'm so thrilled to have you here presenting today. So I'm going to come around with my microphone here.
Dr. Marshall?
Can people hear?
We have
Yes.
one comment
Yes,
so
ma'am.
far online
Yes.
from WebEx. Dr. Stout says, thank you, Dr. Ellington. And here, let me find his comment here. Thank you for leading and growing this work. Your ability to partner, find support, and most importantly, to listen carefully to all stakeholders is truly brilliant. And so lots of nice comments coming online for you.
Wow, great. Thank you very much, Emily. Thanks. Questions from the audience?
Thanks, Laura. This is Anna Hedstrom. Your work really highlights all the multifacets the implementation science takes, and in particular working with the caregivers. And what I'm wondering is if some of that home-based care of what can be a chronic disease in some of these toddlers with probably evolving asthma diagnoses, and the availability for treatment at home is one of the things that, or lack of availability of treatment at home, availability of inhalers is one of the things that may drive or disincentivize providers to diagnose it in a facility when you know you're sending a child home without the ability to treat at home. And so if any of this work do you anticipate it evolving into some of that caregiver home-based treatment and diagnosis as well?
Thank you so much for that question, Anna. As a pulmonologist, chronic care is near and dear to my heart, and I see this project as a gateway to that. Right now, with our experience and in talking to health workers, it's really been lack of awareness that has been driving the lack of diagnosis and treatment, and really this idea that children can't have chronic disease, and that really the IMCI guidelines essentially tell health workers to treat every illness as a new illness, and not history of disease is not really integrated into the care guidelines, and so is really not used in these settings. The IMCI guidelines are being updated currently, and I think that they're going to be incorporating and thinking about chronic disease. But yeah, we are starting early, and our hope is to increase awareness and diagnosis, and showing health workers that kids do respond with bronchodilators. They do get better with courses of steroids and bronchodilators, and not everybody needs antibiotics every time. And then hopefully setting up more referrals to both the national referral system without overwhelming, and then there are interests in the Ginger Referral Hospital where we're working about setting up an asthma clinic there. And I think that will naturally and hopefully then be integrated more into the community health worker and the home health care. In Uganda, the village health team is less resourced than the health centers, and so we've been focusing our efforts there. But I think there's a lot of potential to extend the digital innovation and to also extend the care to the home. That'll be a while from now, but.
Laura, thank you so much. This is truly incredible work that you are leading and doing, and thank you for a great presentation about the tremendous scope of it as well. I am curious, one, what has helped you be persistent with it in the face of the setbacks? Like, where have you found the persistence? What's helped with that? And also, it seems like a key part of this success is helping people, I guess, identify the wheezing component. And are you limited by the technology until that comes around that's going to help with that? Or do you feel like there is some other way to help with the, kind of really the diagnostic component that seems to be missing in a lot of the assessments?
Yeah, thanks, Molly. For the persistence question, I would have to say that the amazing support system that I have has really helped me to be persistent. The incredible mentorship, collaborations, and relationships, and then a couple of successes scattered along the way help as well. So either through grant funding or getting the results from the qualitative study that continue to kind of propel this work forward. And then to answer your question about diagnosis, that's where I think the training program will be really critical. Health workers have the ability to detect wheezing, they have the ability to detect abnormal breath sounds, but if they don't have stethoscopes, and if they're not formally taught to use them, and if they're not kind of prioritized, then I think they don't have the incentive to. So I would hope, and part of our next scale up is hopefully to give stethoscopes, which are not that expensive to people, and to try to come up with creative ways for those not to, walk off, whether it be like personalized stethoscopes or something, and then to incorporate that more into the training program. I think that will hopefully help to go a long way.
Hey, Laura. John with Pulmonary.
Hey, John.
Great to see you.
Thanks.
Amazing
You too.
work and talk. I'm always intrigued when we can reduce antibiotic use, so that's great. My question really, I'm just amazed by the amount of work that you guys put in with the ALRITE app and the first implementation. And it sounds like lots of challenges, but lots of opportunities as well. I will admit some ignorance here and just ask about language. And I guess I'm going to assume that a lot of the healthcare workers speak and can read English, but is that a barrier that you guys had to address? And have you considered using any of the local languages in the app?
Yeah, thanks. So English is one of the official languages of Uganda, and so all of the formal education is done in English. So all health workers will be very competent in English. I think our future and work and hope is that we can then disseminate more into the patient space, and for that we will need to consider more about language. I think that's also a potential benefit of partnering with this nonprofit Global Strategies is to facilitate for those all of those technical challenges and coding and things that are massive issues for me, a non-coder and programmer, that could be done kind of more at scale.
I know we have an online question.
Yes, this question comes from Theta Ong. Can you comment on if there are applications or approaches from your research in international resource-limited settings that you would advise could be applied domestically to enhance care equity?
Thank you, Theta. Great question. She knows how much I love implementation science, so I think she was giving me a softball to talk more about it. I think that there are all of the, essentially all of the methods that I employ and that I try to incorporate into my work can and I think should be used in domestic settings. So the engagement from all stakeholders, identifying stakeholders, engaging stakeholders, and really including them during the design process, getting feedback from them, and this kind of iterative improvement. I think all of those methods are very applicable wherever you work.
Hi, thank you. That was great. It's really wonderful to see the partnership that you've had over the years and what the good work you're doing. I'm curious, thinking about asthma, and what you're saying is most all of the kids aren't getting bronchodilators. They're having asthma respiratory events. And not all of them are dying. So what else are people doing that's not Western to treat respiratory distress? Or have you explored that?
Thanks for the question, Dr. Walker-Harding. I have not fully explored that. I think in addition to antibiotics, steroids are pretty readily used to treat inflammation. And so I think that could potentially benefit. And we're not seeing all of the kids who have those symptoms and who are dying at home. And so we don't really fully understand or know the breadth of what this looks like. But I think that is a very great question and something worth exploring.
Thanks, Laura.
My question was kind of expanding upon one of the things that the healthcare workers brought up about the scope of the app and how it's really focused on respiratory illness. And as an intensivist, I think I love respiratory illness and also recognize that there are a lot of disease processes that cause tachypnea and chest indrawing. So I'm just wondering if what you've started to think about in terms of, as an intensivist, I find that labeling things, so like identifying or even having alerts that this could be sepsis or whatever else increases awareness and urgency in initiating other treatment algorithms. So I'm just wondering, have you started to think about how you might incorporate some of that feedback?
Yes, thank you, Katie, and I'll probably be tagging you to help with this. So we have started with Novi Guide and working with global strategies. We have the potential to make more complex guidelines and more complex branching logic than we were previously able to do. So part of what limited our scope was what we were able to build and think about. And so the ability to expand and partner with this nonprofit, we're already starting to improve the triage system, and so expanding kind of beyond IMCI a little bit, but still aligning with IMCI. And for that triage, we would hope that if that for sepsis or for these critical illnesses, that they would hopefully be flagged a bit more through triage. And then also expanding our scope into what the health workers, so we have also developed an advisory council through this work and are going back to the advisory council to think and talk to them about what are the most common, frustrating, and important chief complaints not to miss, and incorporating that into this redesigned app. And so thinking about dehydration, diarrheal illnesses, fever, malaria, and potential for co-infections, along with malnutrition, which we know is really a big contributor to mortality for all causes, we'll be able to incorporate that into the next phase. And we'll need clinical experts like you, Katie, to help us think through that. So,
Great. Any other questions? All right. Dr. Ellington, thank you for an amazing presentation. Thank you for answering everyone's questions so beautifully. I want to wish everybody a great day, a good week, and we'll look forward to seeing you next week at Grand Rounds.